Welcome today to UOA On Demand. We're here tonight to talk about fracture care and non-unions. I am Dr. Carlos Sagebien. I'm one of the fracture care specialists at UOA. Joining me tonight is Dr. David Polonet and Dr. Sergei Pushilin. Hello, gentlemen.
Good evening.
Thank you for joining me tonight here on UOA On Demand. We're here to discuss the exciting topic of non-union fracture surgery. It's certainly something that we all have to deal with as orthopedic surgeons, and specifically as fracture care specialists. Really falls into our lap in our area of specialty. So I think we could start first with Dr. Polonet. Dr. Polonet, what is a non-union? What is a fractured non-union?
A lot of times, Dr. Sagebien, I get asked by patients when I'm treating a fracture, when is my fracture going to heal? That's a smart question to ask because that's what we're all shooting for. And the reality is that not all fractures heal in the same amount of time. And there's no prescribed plan for a fracture to heal. So we treat fractures in the way that we think is going to get them to heal best and most expeditiously. But we have to keep an eye on the healing process. What we might expect to see an ankle fracture to heal in 6 weeks, or a fracture of the femur to heal in 12 weeks may or may not go according to plan. Most of the time we do see fractures heal over the course of a couple of months, I guess I would say, and it depends on where the fracture is. But we have to see that the fracture is healing both on x-rays and with the clinical course, which is a question of, is the pain improving? Is the fracture stabilizing over the course of time? So we fix fractures and the fractures heal based on the biological principles of how the body reacts to the fracture and the fracture fixation. So we look to see a progression over time going in the right direction. Sometimes we see fractures not healing, that they sort of stall out along the healing process, and there can be a bunch of different reasons that we see that. Dr. Pushilin, you see some fractures that are healing according to plan and some that are not. What do you see as some causes of the fractures that are not healing according to the timeline?
Typically the bone likes to heal in a optimal environment, which any factor that affects that optimal environment can lead to either delay healing or the bone just completely not healing. Some of the most common ones would be when the fracture is fixed, either with rods, plate and screws, sometimes treated with a cast. The fracture can be fixed or exist in a very rigid environment, and then it doesn't have enough normal motion to develop the progression that it usually wants to go through, where the hematoma, which is the blood that forms around the broken bone, forms into callus, which is that typically described as soft bone, and then develop into hard bone. And if it's too rigid, it can potentially not be able to heal and go through those stages. And sometimes if it's too loose or too unstable, it can also not be able to heal. If there's too much motion, the cells can't develop the way they're supposed to. Those are the factors that we can affect how rigid or how unstable something would be. The other factor would be if the tissue doesn't have enough blood flow. Blood flow is vital to any part of the body and any function that the body goes through. So if there's not enough blood flow to the broken bone, the nutrients and the cells can't get to where they need to be, and therefore healing stalls or doesn't happen. This can happen with what we typically see is some severe injuries where the fracture, the bone pops through the skin, or there's big open wounds that will strip the blood supply to those bones. And typically when those things happen, that can oftentimes in many bones, many parts of the body, if that occurs, can lead to a non-union. And we typically take care of these between yourself and Dr. Sagebien pretty frequently, and we can see that pretty frequently as well versus someone in the community. The other big thing that we deal with and we see commonly is infections. Any surgery carries a risk of infection, some more than others. If an infection develops at where their healing is supposed to happen, that again affects the the nature and the environment that the fracture is healing in, which can either stall it, cause it not to heal, or even if it heals, can heal with an infection trapped inside the bone, which can cause issues down the road.
So those are excellent points by both of you. I think it's important what Dr. Polonet said, that different fractures heal at different rates. So one person's fracture that may heal in 6 weeks, you can have a completely different fracture that takes 6 months, and you're wondering why it's happening. It's just bones all have a different tendency to heal at different rates. And like Dr. Pushilin said, the way we fix these bones can also affect how quickly or how slowly they heal, depending on how rigidly we fix them or how non-rigidly we fix them. So those are excellent points to bring up with non-union. So are there any other things you think about, Dave, when you think about causes for why non-unions happen? Is there any specific bones? Is there locations? Is there certain fracture patterns that maybe lead to non-unions that you worry about when you see these patients?
Sure. And just like not all healing rates are the same, not all fractures are the same. And two people can say, well, you know, I had a tibia fracture and mine healed in 6 weeks, and my tibia fracture isn't healing and it's 3 months later. Why is mine different? And the answer is, well, not all fractures are the same. Some of them are low energy injuries. I twisted my leg and my bone cracked versus getting hit by a car. And so as trauma surgeons, we tend to see a lot of variable levels of what we call energy that go into the injury. Sometimes the bone is broken into 2 pieces. Sometimes it's broken into countless pieces, fragments of bone. And the damage, just like Dr. Pushilin was saying, can be significant both to the bone and to the surrounding soft tissues. And when the damage is severe, the healing can be much more slow. So the type of fracture pattern that we see and the amount of trauma to the area can affect the healing rate. Sometimes we even have to go in and help the healing with a secondary surgery, but we're going to talk about that in a little bit. Other than that, there are some bones that have good blood supply, as Dr. Pushilin was saying also, that the capacity to heal is great, whereas others, again, like the tibia, which is right bone beneath skin, doesn't have a lot of muscle surrounding it. The muscle helps provide good blood flow to the area, which is part of the important part of the healing. And so the tibia can be pretty slow to heal, and that can have a delayed healing course. And there are other bones, such as there's a bone in the ankle called the talus. There's one, the hip can have issues with healing because of the blood flow to the area in the wrist, the scaphoid bone. These are areas that blood flow is very tenuous in the first place. And when you have a crack through the bone, it disrupts the blood flow, and this predisposes these bones, because of the specific nature of the anatomy, to have healing problems. And so we have to look at all these different factors when we're taking into account the expectations and the healing process. In addition to that, there's also the person in whom the injury occurs. And so a young 18-year-old who's in great health and great shape and has good nutrition may heal much more quickly than somebody who is 85 years old with significant medical problems, or what we call comorbidities, that can affect the healing process. Some things about the injury can't be changed, such as the injury itself, where the fracture occurs, whether there's a wound, and there are some things about the patient, what we call the host, in whom the healing is supposed to be going on, that can be modified to help the healing process. So I like to engage my patients and sort of say, hey, you can be part of the solution here. If you're a smoker, we know that the nicotine in the cigarettes can adversely affect and slow the healing process. Diabetics have a slower healing rate on average than patients who don't have diabetes, but better glucose control can help with the healing process, so they can be a part of the solution by making sure that their sugar control is better. There are other problems like immunocompromise and the use of steroids, which the patients have no particular choice in, but other factors such as vitamin D deficiency, which we know is important in bone metabolism, calcium levels, that sometimes we can get things into the right order. Other metabolic diseases, such as hypothyroidism, hyperparathyroidism, which is an abnormal circumstance in the body, which can affect the biology of the healing. So the host is also very important, and we have to take all these things into consideration when we're treating a fracture. Dr. Pushilin, I think you have some insight into the types of healing that we see with different types of fractures that can sort of help us get a sort of a systematic approach or an understanding of what the fracture problems or healing problems might be?
Yes. Yes, typically when we first see when a fracture did go on to not heal at the rate it was expected to, or completely not heal at all, we tend to group them into three categories, which one is called hypertrophic, another oligotrophic, and then atrophic. Now, we group them in these categories because they give us additional information. Hypertrophic non-union, which is a specific category, will typically show bone trying to heal and growing more and more bone, but the fracture itself, where the injury occurred, the crack itself, not actually fusing together. So the body is trying its best and it's showing that it can manage to do it, but for whatever reason, it has not. And in those cases, typically, if the so-called biology, the patient's own body is trying to put in the nutrition, the effort to heal it, but it's not happening. Those causes usually we tend to look at, is it fixed correctly or is it fixed rigidly enough to provide to aid the body in actually fusing the two together. The second category would be oligotrophic, where there may be some callus or some healing going on and you see the body maybe showing some signs of that new bone is developing in those areas, but there's not enough that you would or at least not enough that you expect to see at those specific points in time. And those may be a kind of a combination. There might be maybe something biologically is not quite optimal, as well as maybe it's not fixed or lacking fixation as well, that may have to be corrected if we want the bone to heal. And the atrophic category is essentially without any healing that's seen, and that typically the first thing we look for or consider is there something biologically different, kind of to the factors that you alluded to, Dr. Polonet, which is the patient maybe a diabetic that's not as controlled as that he should be, or maybe the nutrition is not optimal. Some factors that patients might not even be aware of that something's going on. But when we see the non-unions, we typically go through those three categories, and depending on the categories, that helps us kind of guide our treatment for the specific fracture and the specific patient.
Those are excellent points, Serge. So, we have a classification system, and in reality, probably all non-unions that we deal with are somewhere on the continuum between the atrophic ones that Serge was talking about, where there's no good blood supply and the bone really has not done anything really to heal at all, to the hypertrophic ones where the bone has tried to heal, but something else is going on with the stabilization of the fracture that's not allowing it to finish its healing. So, and that is all totally dependent on what we talked about earlier with the type of fracture, which is what we're looking at x-rays and how a fracture looks on an x-ray. And then we always need to remember that this, like Dave said, there's a host involved and there's so many things that can play into it. And so I think as fracture care specialists, we are much more likely to look at not just the x-ray, but the actual host. We really are in tune as to why fractures don't heal. And we think about things that other people don't necessarily think about, or they don't stress. And I can't tell you how many patients we've dealt with that the other surgeons really didn't stress the fact that they need to stop smoking or they need to control their glucose. And we order tests that maybe other people don't think about, vitamin D levels, all sorts of things to make sure that patients are as optimized as they can to heal the fracture. So I think that's all excellent points so far. So at this point, Dave, if a patient shows up in your office, it looks like they're being referred to you for a non-union, what's your plan of action? What are we going to do with this patient?
So we really like the systematic approach to the management of these patients, which first starts out with asking questions. Just today, I saw a patient in the office who had been complaining of pain for a couple of months, and she turned out had a stress fracture that had gone on to a non-union. And so what does that mean? That means that she developed a simple fracture in the beginning, and over time it didn't heal. And so we ask questions that are sort of directed at getting to the bottom of, when did this first happen? How long have you been dealing with this type of problem? And have you had any previous management of this injury, such as surgery or any history of infection? So we wanted to know exactly what's been going on, when it started happening, and sometimes we find keys to where the problems may be in terms of the healing. We also go for directed questions about what the patient's medical history is, again, getting at some of the sources of problems where healing can be affected in a beneficial way by us by making changes other than going through surgery. And on the other hand, sometimes the solution is part of the solution would certainly be offering surgical intervention to get fractures to heal. Sometimes we need to realign fractures, and sometimes they're already in good alignment, but we need to adjust the internal environment to help them heal. And so I think that after we talk about the history of the patient and get as much information as we can go on through our algorithm with further investigation. So Dr. Pushilin, I think, there are some additional studies that we order. What's your approach to ordering studies once we've done the examination and the physical examination to supplement the history that we've gotten on the patient?
That is a good question there. Commonly, once you obtain a thorough history and learn everything you can from the patient about what brought them there and what kind of factors might be contributing to their problem, you go to diagnostic studies, which we usually rely first and foremost as orthopedists on X-rays. That gives us a lot of information about just the bone in general, and it helps us also kind of get a sense of the classification, which again gives us more information that we can work with. Oftentimes, X-rays will show you part of the spectrum or the part of the problem, so to speak, but they may not always be definitive, and we try to do more advanced studies. We'll send out the patients for imaging like a CAT scan. Sometimes we're able to perform MRIs as well in very specific cases. And that goes with some of the clinical judgment that we use to decide what to do next. Besides imaging, there's lab work that we consider routine in order to help us figure out what's the underlying cause. Lab works which other doctors may not frequently order or may not have a good understanding of how to apply them to the patient's situation. We often get inflammatory markers to see if there is a sign of infection, like ESR or CRP, which are some of the clinical examples. There's more advanced studies. We try to check for vitamin D levels, which even if they're not applicable to this patient's specific situation, is a good thing to know, because we know vitamin D is an important factor in bone healing and may actually lead us to diagnose or find other problems like osteoporosis in the patient. So that's just kind of some of the additional studies that we typically rely on.
If there's any concern for infection, Dave, like Dr. Pushilin was talking about the elevated inflammatory markers, how do you go about trying to ultimately prove or disprove if there's an infection?
Yeah, we always try to do the least invasive investigation first, and that includes some of the lab work and some of the radiographic studies. But it's been shown that even the lab work that looks for infection can be very notoriously misleading at times. Sometimes it can be very, very helpful to confirm a suspicion of infection or some other abnormality. And sometimes we need a little more information. So we go through a stepwise approach where we become more interventional and we try to get as much information as we can, so that if we have a surgical intervention that we're going to recommend, that we can make sure it's directed in the right approach, in the right direction. So Sometimes we need to know specifically, is there an infection? And if there isn't an infection, that's documented. And a lot of times we're talking about infection with non-unions because that's one of the key sources or causes of fractures not healing. And we have to sort of be on the lookout for that, because if we don't know that there's an infection and there is an infection in a fracture area, and we go to address it without understanding that there's an infection there, we may be going down the wrong pathway, and we really want to avoid doing that. Sometimes we'll do a surgery where we do an actual biopsy, which is a procedure where we make a much smaller incision, do a much smaller approach to addressing the fracture, and we clear out the fracture area, and we actually culture the tissue in the fracture area. We look for signs of infection, and we culture the bone. Otherwise, we can also send it for pathologic investigation to make sure that if there's no history of other factors such as a tumor in the area that could be affecting the healing. So there's a lot of information that we can get as we become more invasive and more interventional. And this helps us plan an approach to surgical reconstruction of a fracture to really optimize the healing environment and do it the right way the first time, so that we don't have to go back and do additional procedures.
Great. So basically, it's the same algorithm that we all use. We're all trauma fracture care specialists, and we all always start by talking to the patient. We then order X-rays or CT scans, and then we get lab work, which helps us to put the whole picture together. Once we have an idea that we can know what is specifically going on with each individual patient with individualized care, we can then proceed with treatment. And as usual, I think that the treatment always begins with the patient, and we need to do the things we need to do to optimize the patient, or as Dave said earlier, the host, to make sure these patients are going to heal the fracture and try to avoid multiple surgeries, which unfortunately happens with these non-unions. That can be very difficult to get to heal. So we frequently will involve the endocrine doctors, plastic surgeons, just the medical doctors to help optimize our patients, to get people into smoking cessation, get people to their endocrine doctors to control their glucose better. If they have vitamin D deficiency, we send them to our endocrine doctors as well. Sometimes you need high doses of vitamin D to correct your deficiency. And up to 42% of patients in the United States actually are vitamin D deficient. So it is something that we see frequently that maybe other doctors don't think about as much as we do. So we optimize the host, and then we treat the non-union. And as Dave said, unfortunately, infections do happen, and infections are some of the more difficult or challenging non-unions that we deal with. Dave, how do you deal with an infected non-union?
Yeah, it's because these are so common, we end up talking about this so often. And in our own conferences that are specific to trauma specialists and fracture care specialists, we spend an inordinate amount of time discussing what do we do about the fracture that's not healing and has an infection. And so a lot of times these are infected because there's an open wound, there was a significant contamination of a fracture that happened in the beginning of the time when the injury occurred. And these infections can be really hard to prevent sometimes. And when we identify that there's an infected non-union of a fracture, then what we end up having to do is we need to really clean out that area and almost sterilize the area where the infection is. And that requires surgery to go in, clear out any bone that's been really compromised by infection, clear out any bacteria, pus that's in the area of the infection. And again, these can be really subtle. So sometimes you have an infected area of bone, and because bone doesn't always show an infection, it can actually hide an infection for a while. We have to go in with our suspicion that there's an infection, get a culture, and clear out the bone until it's all healthy appearing. And through our experience of treating these fractures, we know what good bone looks like, and we know what contaminated or dead bone looks like a lot of times. And then once we remove all the bone and the tissue that's compromised by an infection, we also have to make sure we get any metal implants that are in there, because once those get infected, those have to come out too. So sometimes we need to do a staged approach to how we treat these. In other words, number one is get out the infection, get the infection out and make sure that we cleared it out well enough with multiple operations to make sure that we have cultures that show that we've done a good job clearing out the infection. Now we can have a reconstructive process where we replace the implants in there with both internal or external fixation. So that's internal fixation is the metal plates and screws, the metal rods that we use inside the bone to stabilize and align the bone. And sometimes we use external fixation, which is like a halo that goes around the leg, if it's a leg or an arm, and we hold the bone in position while we do a reconstructive process, which can involve grafting of bone in areas where the bone has to have been removed because it was infected. So we can take bone from one area of the body and put it into another area, and that's called bone grafting. Sometimes that's the right solution, and sometimes we need to give the area, before we do bone grafting, a period of a temporary implant with antibiotics that's loaded into the implant, and we call a spacer. This is a technique that was devised in France and has been sort of applied in multiple different areas of treating these infected non-unions. And sometimes we have to do some really complex reconstructive procedures where we grow new bone by using implants that can actually lengthen an extremity or transport bone across an area where there's a hole, and these become very complex procedures. So we have a lot of weapons in our arsenal for treating non-unions and growing bone where there's been a problem before. But it's a tough problem, and we work there's a lot of work that goes into reconstructing these injuries.
Yeah, it's a big effort for sure. And like you said, I think, our experience with these is that we really know how to clear out infected bone, where I think a lot of surgeons are afraid to do that because it just sometimes is very daunting that you're removing so much bone. But if you don't get rid of the infected bone, you don't get rid of the dead bone, it'll never heal. So it's really, really important part of that. So on the bright side, Serge, we do sometimes, more often than not, hopefully get to treat infected, non-infected non-unions, or bones that didn't heal but are non-infected that we discussed before with the hypertrophic or the atrophic non-unions. What's your plan for both the hypertrophic non-union, and then after that, tell us what you do with an atrophic non-union?
Kind of what we discussed initially. Yes, if you're fortunate enough and you have a clean or a non-infected area, but you have a bone that hasn't healed, that's almost a completely different pathway in how we approach it. So in some senses it can be not easier, but less complex or less time consuming or less invasive for the patient, that we can see if we, for example, see a hypertrophic non-union where the body is actively trying to heal it. It just needs a little push, it needs a little help, and we typically can do that with surgery once we addressed all the other factors like patient factors, ruled out infection. Oftentimes we can, bones, for example, like the femur or the tibia, which can sometimes develop non-unions, we can use rods to stimulate bone and to stabilize the bone appropriately to cause it to now heal. Sometimes we use plate and screws, or a combination of both, plate, screws, and rods that we use for hypertrophic non-unions. Because in typical case scenarios that we see, once we see quite a significant number of these, we can sometimes use our clinical judgment and our experience to decide this bone just needs a little push through surgery that I'm going to do in a specific manner, as opposed to atrophic non-unions where you see that the biology, the patient is not, the bone itself, the body seems to be lacking something to heal it. And in those cases, we would use both techniques to stabilize the fracture with plate and screws and rods, such things, and add biology, which is what Dr. Polonet alluded to. We can harvest bone from other parts of your body, from the bone marrow or from inside the pelvis, to actually add into the gap, into the missing area, to now the body has something that it can use to finally heal that fracture. sometimes we can use man-made biologic products that we typically actually see that a lot of other surgeons may not come to use as often, just because we do deal with non-unions more frequently than I would say other orthopedic surgeons would. And all of this is available to us. And along with, there are some advances that are still being developed that we keep an eye on and keep up to date with constantly through research, through reading publications, through participating in conferences that we can then use in trying to treat the hypertrophic and oligotrophic, atrophic, all the different types of non-union that we take care of.
Some of these can be the most rewarding cases, most gratifying cases that we take care of, because people come to us with problems that have been lingering and causing them disability and pain, and we can offer them solutions. Now, we don't have a 100% success rate, nobody does, but we can offer solutions which sometimes through a pretty straightforward intervention that we can get them to healing, return them to function, and pain-free function too. And so it can be very gratifying both for us and for the patients who are treated.
Great. Well, thanks for joining us tonight, guys. I think as come through in this talk, these can be very complex issues to deal with, and they can sometimes not be so complex. But the bottom line is that each patient is different, and we need to treat each patient as different. It often involves a multifactorial approach with our partners, from even other subspecialties in orthopedics. We've got hand surgeons, shoulder surgeons, foot and ankle surgeons that can help us. So we've got specialists in every subspecialty in orthopedics that come to our help. We also rely heavily on some of our medical colleagues to help optimize the patients. And the bottom line is that as I've mentioned, each fracture is different. It's not necessarily something that the patient did wrong. It's not necessarily something that the surgeon did wrong. Unfortunately, non-unions happen. I guess you could say death, taxes, and non-unions, unfortunately, for the orthopedic doctors. So the bottom line is that they happen. We feel that we're very well equipped to deal with them. And we encourage you to stop by uoanj.com for further information on any orthopedic injuries you may have, including non-unions. Thanks for your time.
Thanks. Good night.
Thank you.